Hi, everybody. I'm. This is a supplementary. I'm going to have to, with regard to missing on Wednesday, and I apologize. It's the second Wednesday in a row where I've just all of a sudden in the afternoon felt lousy. I was able to do it 2 weeks ago, be in lab, and got home was ill. But today, this Wednesday, it just didn't work this past Wednesday, so I apologize. And the only difficulty with this is it's going to delay, at least by a week, our having the practical. So the way the practical is, and I'll show you the calendar. I was hoping to have it here. We're going to have it on the 25th. So next week I'll be able to give you ample opportunity to look at the bones, and I'll be able to demonstrate some of the bones that are there. And then on the 25th we'll have the practical. That's the plan of attack as we speak now. So I just wanted to show you that from a standpoint of what's going on. Uh, but I will be able to present what I call the didactic, basically the lectural part of the program now, and that's what I'm planning to do as we speak. So this is the portion that we'll be doing. I'll just do it like this, so that there's any problem with it. And we had done the skull previously, as you recall, and talked a little bit about the hyoid bone at the end, but that's not a big deal on this. And so the spine or spinal column, okay, is 26 vertebrae. The distribution is not, it's 26 in a sense, but really there's fused bones that actually make it a little more bones. Not that that's a big deal for you. There's 7 vertebrae, and I have to demonstrate the vertebrae to you. They're irregular in shape, but I want you to know the difference and the distinction between cervical, lumbar, and thoracic. It's not that difficult to do, but I do wish to show it to you. That's there. So 7, 12, and 5, if you add that up, that's 24. We consider the sacrum, even though it's 4 or 5 vertebral bones fused, and the coccyx, maybe 2 or 3 that may be fused, as being one particular bone. That's not, again, it's not a big deal. So 7, 12, and 5, as you can see. And again, even though the fusion is there or the fusion is here, we consider it as one. The interesting thing are the curvatures. So you're going to see them. This curvature that you're born with, when they talk about convex posteriorly, imagine the fetal position with the baby curled up when it's born. We call that the primary curvature because that's what you're born with. The secondary curvatures, and what happens is at both the cervical and then later on the lumbar level, the curvature assumes what we call the secondary curvature. It's no longer convex, it's concave. Just feel the back of your neck. You have an indentation, that's concavity. The lower back, that's a concavity. And so what they are associated with are two of the two most singly important signs of development that we can sort of put a clock on in babies, and as they become children, as they go from infants to sort of toddlerhood. What happens 3 to 6 months? The cervical curvature effectively demonstrates itself, and the baby controls its head. So no longer do you have to support the head, it can support its own head. And then on average, between 12 and 15 months, there's a wide variation from probably as little as 9 to as much as 18 months. Nothing of those, anything in that realm is unusual of the lumbar curvature, and that's when we can see a baby begin to stand and walk. So those are the landmarks that are part of it. So they're showing you what it looks like straight, and now these are the mature curvature. So if this is posterior, this is anterior. So in your back, you have the neck being now demonstrating a concavity, primary curvature, the convexity in the thoracic sacral area, but not in the lumbar. That's the point they're trying to make. Here's a lot of ligaments that hold this together. You don't have to go through all the names of them whatsoever. You can look at this illustration. All it does is it demonstrates to you how important the ligamentous structures are. There's a lot of movement for bones that only move a little against each other. So what you will see when particularly look at joints is these tiny processes that are point upward and downward. They come together and they glide and slide. But when you have, let's say, 24 of these segments moving, a little bit each, it makes for a lot of motion. What you can see here, and why the discs in between them are so important, they maintain this opening roughly rounded or oval. It's called the intervertebral foramen. And so the foramina, intervertebral, are where the spinal nerves go outside to side. And the spinal cord itself is going through this much larger opening called the vertebral foramen, which you'll see shortly. You can see here that the discs are mostly fibrous, but they have a soft center. So annulus fibrosus means they're a rounded or circular shaped disc. And in the interior, you have a pulpy nucleus. It's like a soft kind of gel-like center would be the best way to describe it. And it's the remnant of something that vertebrates have called a notochord. So vertebrates, they're remnant of this notochord. There's three things that vertebrates have. They have a dorsal hollow nerve cord, that's the vertebral canal. You have the notochord, which is the anterior to it. The remnant of that is the nucleus pulposus. And they have pharyngeal pouches, because if you think of fish being vertebrates as well. So they have gills. We have our middle ear canal. Still have a little bit residual cough. And so here you can see this sort of an interesting sandwich between the vertebrae, as was bad. So when you're just think of exercising, doing a sport, jumping up and down, elasticity and compressibility, but the overall strength is the outer collar, this annulus fibrosus. And this is what happens when it ruptures. Typically what ruptures is not so much this area that you can see here. The annulus fibrosus, what happens, it weakens, okay, typically anteriorly in the front, and it allows the disc to protrude or herniate. And so you hear the name of a herniated disc. A hernia is anything that's protruding somewhere where it shouldn't be. And depending on where the impingement is, where it limits this, if it collapses, if it causes an irregularity, it's going to act on this nerve. This is typically a spinal nerve going in one direction or the other. And depending on where it is, it can affect numbness, weakness, pain, tingling, needles and pins, whatever you want to call it. And they're showing you here an MRI that's demonstrating that, and you can see what's happening. It's pushing in what appears to be the spinal cord, but the reality is that it's kind of pushing in and impacting that nerve where it's protruding out usually. Sometimes it can be on the cord itself as well. And what MRIs do, if you did not know, they're useful at looking at different densities. Things that are very, very closely packed or have air or are loosely packed. That's where you see these different densities. That's what MRIs are particularly useful for. Okay. So anything can cause these types of problems. Normally they're traumatic or they're arthritic, different things like that. And the treatment is very much based on the severity of the symptoms. I had a disc bulge like this or herniate slightly back 10 years ago. I've been treating it ever since with basically sort of occasionally anti-inflammatories, chiropractic adjustments, exercise. Did not want to think of anything about surgical intervention if possible. I take very, very little in the way of painkillers for it. And I try to stay away from the anti-inflammatories as much as I can. Here are abnormal curvatures as well. That's where we begin to see a side-to-side or a lateral rotation. It's called scoliosis, which is relatively common. You have we have both kyphosis, which is referred to as a hunchback, and lordosis. And there's somewhat of a misunderstanding, as you'll see the illustrations. The scoliosis is, depending on the severity, has to be treated. Not everybody has it. Kyphosis or hunchback is something that we see a lot more in the elderly and different compression fractures in the vertebrae, where the vertebrae weaken from osteoporosis, and what happens, or some damage to the spine from some other disease entity, and it cannot support the head, and the head sort of tilts forward. That's not like the very famous movie and novel called The Hunchback of Notre Dame, where that was actually someone born with deformities that created a hunchback, some unusual assortment of bony deformities. And lordosis we typically see more probably in pregnant women than anything else, is the illustration. So here's severe scoliosis. This is more osteoporosis based, this bump that we see here from that portion of the spine sort of protruding, and that's that array right there, and that arrangement there. And then here you can see obviously someone's pregnant, and we can see the lordosis. So just be familiar with them. This is what's when your physician, when you're doing an eval, or a nurse practitioner doing an eval, will have you lean forward. They'll run their finger right down your spine, and if you get an S curve, it's scoliosis. And the reason we use the term spine, as you will see, that in vertebrae, the name of the point that protrudes, particularly so when we bend over, is called the spinous process. So we'll look at the general pattern of vertebrae. They have a body which is anterior, that's the weight bearing. Vertebral arch is called pedicles and lamina. Pedicles and lamina form the surrounding, like the four corners that surround very, very thick plates. The vertebral arch would enclose the spinal cord. That archway is called the vertebral foramen. When we stack them one on top of the other, they become the arch or canal. And the intervertebral I showed you before, they are sideways openings that come from one vertebrae sitting on top of the other. As long as the disc is functioning, it works great. So you'll see this illustration undoubtedly on the practical. And what it shows, you'll have to identify the parts that protrude, and they aren't always as distinctive. They typically use a lumbar vertebrae because everything is kind of larger. The posterior process is called the spinous process. That's where you get the name spine. The transverse or side-to-side processes, and this one, interestingly enough, because you have that area here, that's called a facet. So this would be, rather than being lumbar, when you see a facet like that on the transverse process and on the body here anteriorly, those are where the ribs join, and those little, what we call facets or demi-facets, because they're like half facets, are able to allow a certain amount of movement of your rib cage. And you can see the opening here. The lamina are here, and the pedicles are obscured a little bit. They're up front. And this is what since we're looking at it from the top down, this is what these are: superior articular processes with their own facets that allow one vertebrae to articulate or join the other. So as you can see, they have 7 processes: spinous, singular in the back, 2 going side to side or laterally, 2 going up called superior, 2 going down inferior, and the inferiors of one articulate or join the superior of the one below. What's interesting about cervical vertebrae is they're very, very distinctive. Yes, they're very, very small, and that's kind of the giveaway. And they have a lot, they have a fairly large vertebral opening or foramen because the spinal cord is quite thick there. So they have a large triangular vertebral foramen. But the big giveaway is on every cervical vertebrae, if it's intact in the specimens we have, and I'm going to show them to you when we meet next time. I'm going to take them out and show them to you, just to comment on each one of those so you know which is which. They all have what's called a transverse foramen. This is interesting. When you stack up the cervical vertebrae, these transverse foramen make up a canal or passageway. And whenever you have a bony passageway that's a passageway that, let's say, is surrounded by bone, something important is in there. And in this case, there's something important. It's called the vertebral arteries. They're the backup circulation to your brain. Your brain is fed mostly by the carotid arteries, and you can feel the pulse right behind the angle of your jaw. But immediately behind that, and protected by this series of bony enclosures, is the vertebral artery. And the largest of these is C7, and you can feel this as a landmark, and that's something you learn about with surface anatomy. So C1 and C2 are unique. C3 and C7 keep getting larger, but all of them have the transverse foramen. So this is a typical view of the different vertebrae. It's hard to tell because you're not looking at them. These are, the transverse foramina are not impressive. What we do see, because of the ligamentous pulls, frequently we see what's called a bifid or forked. That's what bifid means, 2 prongs or more. Spinous process. You can see the large triangular, almost disproportionately large triangular opening, and here you can see in these small transverse processes, the transverse foramen. Whereas here, when you see the thoracic from the side, the spinous process is distinctive and long, and it points downward. You have a decent size opening, albeit smaller. Okay, you have very distinctive transverse processes because of the ribs, and you have those little demifacets on the body and on the transverse process for each of the ribs that are there. That's a giveaway too. And then lastly, even though it's not drawn to size, these are much larger. The lumbar have a very short, they call it like an axe handle, spinous process. Very distinctive transverse processes, a disproportionately small opening for the vertebral frame. And this is what I meant. So again, not drawn to scale, but these are much larger. The lumbar are much larger. It has that short sort of axe handle spinous process or axe shaped. Here with the body, and I'll demonstrate this when I have the bones in front of everybody in class or in lab next time. You see the spinous process always points down. It's a dead giveaway for thoracic. And in lumbar, you will see the opening in the transverse processes. The unique ones in the cervical, a big part of the cervical, the unique opening of the transverse processes. In cervical, you have 2 very distinctive ones. They're called atlas and axis. Atlas, or C1, has a giant circular opening, and it doesn't have any real body or spinous processes. It's got masses that basically are where the condyles remember the occipital condyles, join it. And basically, if you think of the S motion, those are the occipital condyles moving against these sort of oval-shaped openings or oval-shaped facets on the atlas. So remember, atlas mythologically holds up the skull. That's where its name comes from. So it looks like this. And so here, these are convexity, and so the occipital condyles fit in them. They're called lateral masses. And you'll see on the next one, they point a little bit differently that are there. But there's no real body. You can see the transverse process. You can see the transverse foramen. And here you can see them underneath, where, again, you can see a little bit more looking at them from the inferior view. You can see that they have facets that are going to meet the next series of they'll meet the superior articular facet of C2. So you can see way up here, C1. Now C2 is called the axis because it has what looks like an unusual knob-like projection pointing upward called the dens, because they've been dental. It's also known as the odontoid process. It looks like a tooth, like somebody's missing all their teeth except one. And it points superiorly, and it fits in, and it's kind of what they're making a statement here. It's kind of like going to sit right in here. It's almost like the body that wasn't there. And the dens is really like the body of that particular articular facet. Okay, and it pivots. It's one of you have 2 pivoting joints. One at your elbow, where your elbow, if you hold your elbow at 90, you can turn your palm down and turn your palm up without the elbow moving. That's a pivoting joint between the radius and ulna. We'll get to in joints, which we won't do next week, we'll probably do the week after. And then the dens, okay, is a pivoting joint between C1 and C2 that allows you to move your head like you're moving your head side to side, saying no. And so here it is again. So you can see this is the mated area to the articular facets that are there, concave here, probably more convex on C2, and effectively they function as one. There's, you can see the real bone itself, and they kind of look like that together. So they really are a unit that allows this kind of joint is called a condyloid joint. We'll get to that in joints. So it moves, it flexes and extends, and you have a certain amount of side-to-side movement and rotation available. And this one is clearly pivoting, so you can really move your head aggressively from side to side. And it's held in by a ligament. That's that very unique joint that we see there. The thoracic vertebrae, okay, are small and they get bigger as you get all the way down. So again, the difference between a lumbar and the first lumbar and the 12th thoracic vertebrae, sidewise, they're very close. So it's really, you don't want to look so much at size, you want to look at characteristic. The body has those little facets for the ribs. The foramen for the opening is more circular than triangle. Okay, the spinous processes point inferiorly. The transverse processes have little facets, little areas where you can see the ribs will attach. So, and this is kind of what they look like. You can see the disc, the intervertebral foramen, even though it's not pictured, would be in here. You have a lot of nerves coming out each one. You have 12 thoracic nerves. They innervate the area that helps us breathe. They control the chest and expanding it or letting it relax, etc., for breathing. Lumbar, so-called small of the back, is indent, and it's really the high stress point. Most of the problem when we see disc problems, like I have, are in the lumbar area. That's really where, depending on your activities, people who, hear about back, typically it's either lumbar, it's been my experience at least, and I don't know if this statistically is true, lumbar and cervical. Short, thick, they're big. Thick, because they take a lot of force. The hatchet or axe shape spinous process. Again, even more triangular, even flatter. And you can see how much it's less because you have less spinal cord. Spinal cord gets thicker as it goes up because more nerves are coming in and eventually going into the brain. And it's quite distinct. There you can see it here. The sacrum, the only thing I'm going to ask you is to identify the sacrum. There's not a lot of anatomy on it. There is, but it's these bones are fused together. So you have ridges in the back where the bones are fused together. You have the openings rather than the nerves where you're going out side to side because of the fusion kind of go out front to back. So you can see all these crests and things and openings, etc. So it looks kind of like this, but the spinal nerves, rather than going out sideways, are going out much more in that front to back kind of a thing, just the orientation. What's interesting here is it looks like a little ear, particularly when you look from the side over here. And that's called the auricular, because it looks like an ear, surface, and it's mated to an auricular surface on the bones that make up your hip. And that's the very famous sacroiliac joint. That's where your lower extremity meets, that's where that's where the appendicular, this is part of axial skeleton, and this meets appendicular skeleton. Here's that auricular surface, and you'll see it. What's left, I'll show you the ribs. There's not a lot to them. They're very distinctive. The sternum, and I have sternum, I have real sterna that are so small and beat up that it's really hard to identify. So we'll be using a model in plastic, and the sternum has 3 bones, but effectively we view them as one. So because they all fuse together. The uppermost portion is called the manubrium. It's got a notch in the middle, sometimes called the sternal or manubrial notch. That's a palpation point. That's kind of like dead center in our neck. And we use that a lot if someone has to have a tracheotomy. If there's damage to the neck and there's so much swelling, a person can't breathe, you'll insert a trach tube in there. So that's one of the ways why we're very aware of that. Okay. Then there's a slight angle here, and this is the body of the sternum. This is where you put the heel of your hand for doing compressions with CPR. And this is the point at the bottom, which is somewhat more cartilage than bone until we're about middle age. and that's called the xiphoid part. Eventually, that becomes all bone fused together. And emanating, or rather attaching from each of the ribs, 1, 2, 3, 4, 5, 6, and 7, and 8, 9, and 10 also join up with 7. Those are called costal, which means chest or related cartilages, C-O-S-T-A-L. So the costal cartilages are all important. So ribs 1, here, 1, 2, 3, 4, 5, 6, and 7 are considered true ribs because, so here's 1, 2, 3, 4, 5, 6, and 7, because their cartilage goes directly into the sternum. What makes 8, 9, and 10 false ribs is their cartilage first joins with each of these cartilage join together and then join 7. And what makes 11 and 12 false is they don't have any cartilage at all. And because they don't directly or indirectly join the sternum, we call them floating ribs. So true ribs have cartilage that goes directly into the sternum. That's 1 through 7. 8 through 12 are false, with 11 and 12 being floating ribs. And you'll see this on the diagram. You're going to need to know this manubrium, this is the body, this is the xiphoid, and these are the costal cartilages. If you know that, you're in good shape. Breastbone, etc., doesn't all come together until about middle age. Okay, that central indentation is really important. Again, we use that a lot. There's a lot of when someone has a neck procedure done in surgery, we're always worried about swelling. So people have to be ready to do a tracheotomy if that person can't breathe for it. It's easy to reverse, but you don't want to play around with it. That's there, and this is the whole thing with CPR. You can read through that, and I'll just show you the ribs. The most important thing for you to do with a rib is to identify it's a rib, for lack of a better way to express it. So you know it's a rib. Remember, ribs are axial, and when you're going to see something shortly, that's the clavicle, that's appendicular. It looks a little bit like a rib, but it's not rounded. It's not terribly flat. There's a more substantial aspect of the bone. And you won't have to know any of this anatomy from the rib. And we have a lot of real ribs that you can look at. And here, this is where the head of the rib touches the body of whichever thoracic vertebrae it is. And here you can see this articulation where it touches, and it kind of curves around this way, or this is the front. So it kind of curves around that way, in that regard. There you see the head, the facets here, another facets here, and it curves around to the front, and this is where it'll join the costal cartilage. This would be one of the longer ones, like 6 or 7. And that's that. And that, I'll just introduce this because it's really much easier for me to show you the extremity bones, for real. But we're going to look at 2 sets. By definition, the connectors, the shoulder and hip assembly, which are referred to as girdles, pectoral girdle and pelvic girdle, are by definition part of the appendicular skeleton. It's the appendages themselves, arms and legs, and how they attach. The pectoral girdle, you're going to see we have we have one wired together, shoulder and clavicles, the collarbone. So clavicle and scapula make that up. Clavicle in the front, scapula is much more posteriorly oriented, and that's the sole connection, is where what's called the sternal end of the clavicle joins the top of the sternum. Because the whole way your upper extremity is attached. That's why you have so much motion. It's all about mobility. That's the good news. When you have a lot of mobility, you don't have a lot of stability. And you'll see when we take a look at the shoulder joint itself, how it's easy to damage that assembly. We get shoulder separations and shoulder dislocations. Because we have so much mobility, we don't have a lot of stability. The scapula are not connected other than at that sternal area to the axial skeleton, just that one site. And you'll see that the juncture point between the clavicle and the scapula is relatively weak. That's where we separate a shoulder. And the socket of the shoulder isn't much of a socket at all. It's relatively flat. So this is the acromial. Here's that one. This is the point of attachment. Clavicle to sternum. Here's the clavicle, most frequently broken bone in the body. When somebody falls and you put your hand down to brace yourself, most of the time it's the clavicle that takes that, particularly if you're falling from a distance. And you put your hand out or your arm out, depending on how you put it out, you can either fracture a clavicle or get this, which is a separate. When you hear about separated shoulder, it's not down here. That's a dislocation. Up here is a separation. The acromio, which is called the acromion process, and the clavicle, so we call this the AC or acromioclavicular joint, is two really flat surfaces that slide up and down against each other. They're easy to knock out of position. And so there are different grades of these separation. If you just move it a little bit and it hurts, grade 1. If you move it enough that it starts to lose contact, grade 2. And if it loses, these bones actually separate completely, grade 3. Most times grade 3 after operate. And then we'll look at the humerus itself when we get there. So you have a sternal end and an acromial end. The sternal end is much bigger, okay? And it's a really important area because there's a lot of muscles that hold on to the scapula and play a role. So here's the sternal end, which you're going to see is more triangular, and this is a little bit flatter. This is called conoid tubercle. You don't have to know about it. But this acromial end is very, very flat. That's where it meets the scapula. And the scapula we'll see is a lot of anatomy. It's easier for me to show it to you. But from the back, that's your shoulder blade, known as the spine of the scapula. From the front, this is the acromion process. This is called the coracoid process. And this glenoid, that's the socket. It's not much of a socket. It's relatively flat. We'll get into that. We'll get into all of those things. And we'll look at the arms themselves. So I'm going to stop it here. I just wanted to introduce this. And the other one, I'm not quite done stopping it. So I work my way down, is at the pelvic area. And again, there's the sacrum. It has an auricular surface here. And so this is a little bit different. It's inherently more stable because it's not a two-bone assembly. It's 3 different bones, here, 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 basic 1, here, number 2, here, number 3, that are effectively fused together. And then they embrace with a very, very large joint, those 2 ear-like or auricular surfaces, rough edges together, makes it very stable. And then they're held together anteriorly by a disc that's very, very similar to the intervertebral disc. And indeed, we use the same term when we get to joints. This is called a symphysis, symphysis. This is the symphysis pubis. So we're going to look at that in the bones. And when you see the socket, I just want to complete that thought. This is quite a distinct socket. The socket's got a famous name, the acetabulum. And the acetabulum is comprised of 3 bones, which are the ilium, the yellowish one, this sort of purplish one, pubis, and this sort of reddish-orange one. The purplish one is the ischium, and the reddish-orange one is the pubis. And yes, now I'll stop it here. And because it's going to be easier for me to demonstrate those when we get to class, and I will, and it shouldn't take so long, and then we'll get into joints. So thanks again. And I'm going to show all these bones to you. Again, apologies for you not being able to be up to it to talk to you on last week on Wednesday. Bye-bye.